So hello everyone, and welcome to today's abstract presentation session on Indigenous health and wellbeing. My name is Kalinda Griffiths and I am a proud Yawuru woman. My country is in Broome in Western Australia. I'm also an epidemiologist at the Centre for Big Data Research in Health at the University of New South Wales. Before we begin today, I would like to acknowledge the traditional custodians of the lands on which we're meeting here, all across the globe. I'm calling in from Darwin in the Northern Territory in Australia, so I would like to acknowledge the Larrakia people, the saltwater people, and I would like to pay my respects to all elders, those of the past, the present, and the future. Just to let you all know, we do have a chat function. Those of you who have been in sessions before will know all about this. So please put your questions into the chat function as we go and as the speakers are going as well. We will go through the speakers first, each get 10 minutes, and then we'll have a question and answer time at the end. First up, we have Miss Megan Ladbrook, and she's going to be speaking. Oh, Megan is a data analyst with the Data Integration and Analytics team in the Department of Education and Employment, and she's previously worked in Indigenous STEM education in WA schools as well as the CSIRO. Sorry, I don't have presentation detail in front of me, but I'll let Megan speak to her title and I'll get up the other presentations. Megan, if you wanted to start sharing your screen now.
Thanks, Kalinda. Yep, I'll just share my screen. Oh yeah, so good morning. My name is Megan Ladbrook. So the research I'll be discussing today is examining bachelor's level completion rates for Australian Aboriginal and Torres Strait Islander students using matched population level data. Kaya, I would like to respectfully acknowledge the traditional owners and custodians of all the lands on which we meet today and pay respect to their elders past, present and future. I would also like to extend that respect to all Indigenous peoples from around the globe who have come together today. I'm lucky enough to have grown up on and currently live on Whadjuk Noongar Boodja in the southwest of Australia, a region with a continuous culture of at least 45,000 years. On the slide is a photo I took of the Derbarl Yerrigan with Carter-Garrup in the background. Carter-Garrup is the region the Waggal emerged when it created the Derbarl Yerrigan. The Department of Education, Skills and Employment, or DESE, is responsible for the wellbeing and economic benefits that quality education, skills and employment provide. Our team's previous research on the impact of higher educational attainment as measured from year 11 and below to postgraduate qualifications has shown that increasing levels of educational attainment were positively associated with better lifetime employment and income benefits and other health benefits to the individual and society. Supporting student Aboriginal or Torres Strait Islander peoples through higher education will help address other key areas of disadvantage, including those identified in the Closing the Gap report. The Australian Government has a priority to improve the wellbeing and opportunities of Indigenous peoples in Australia. To ensure this research is culturally appropriate and respectful, it has been done in consultation with the Department's Indigenous Advisory Committee at Indigenous Education Consultative Meetings and our internal diversity and inclusion team. Australian Aboriginal or Torres Strait Islander student enrolments have more than doubled over the past decade by 201%. This is in comparison to other Australian student enrolments, which has only increased by 46%. The dropout rate in first-year students is higher and 6-year completion rates remain lower than other Australian students. This research was done to try to determine the factors which leads to these rates. The research was undertaken as part of Shah and funded by DIPA. DIPA was a 3-year investment to maximise the use and value of the government's data assets. Shah was one of the analytical units of DIPA, combining efforts from the education, health and welfare sectors. The data analysed uses MADAP data, so the Multi-Agency Data Integration Partnership, which is a partnership among Australian government agencies to develop a secure and enduring approach for combining various government datasets to create a comprehensive picture of Australia over time. A number of the datasets contained information pertaining if the person was an Australian Aboriginal or Torres Strait Islander. A variable was created by the Australian Bureau of Statistics if any of the datasets listed the student as Aboriginal or Torres Strait Islander. This isn't a perfect measure, as some people may intentionally or accidentally mark themselves as Aboriginal or Torres Strait Islander that are not, and vice versa, but it was the best measure we had at the time, and the proportions of Aboriginal or Torres Strait Islander students was similar to other findings of approximately 3%. Due to the limitations of the data, we only analysed domestic students who commenced in 2011. This gives us 6 years of data. Obviously, this isn't a lot of time to complete for students who are studying part-time. This was able to be expanded from 2005 to 2016 for one piece of analysis, looking at the 6-year completion rate by age at commencement. The MANUP dataset is linked and managed by the Australian Bureau of Statistics using highly detailed de-identified unit level data. Linkage rates for this project were above 90% and the overall quality was high. This analysis is part of a larger study named the Better Understanding the Impact of Health and Social Factors on the Transition from Education to Work. So the datasets that were included in this analysis were Social Security and related informations, Census of Population and Housing 2016, Higher Education Information Management System, Personal Income Tax and Pay-as-you-go summaries, Registry death data, Medicare Benefit Schedule, and Pharmaceutical Benefits Scheme. Background issues of equality known at or prior to enrolment can have a profound effect on student completion rates. Excuse me. A number of equity groups were created using student data linked to health, tax, social support, and demographic data. Equity membership is defined as belonging to any of the following groups: originating from a low socioeconomic background, having no parents with higher education qualifications, the use of Medicare or Pharmaceutical Benefits Scheme mental health items, Medicare chronic health management items, living with a disability, being an Aboriginal or Torres Strait Islander Australian, or coming from a regional or remote area. We found that student income support has a positive correlative influence on student Aboriginal and Torres Strait Islander Australians' university completion rates. The greatest increase was in relation to undergraduate student Aboriginal and Torres Strait Islander Australians who came from a regional or remote community and have parents who have not attained higher education qualifications, going from 46 up to 65% completion. This shows a possible link that even a small amount of government income support can have a positive impact. And please note that these groups are mutually exclusive. Even after controlling for these factors, however, indigeneity was still found to impact the likelihood of completion. This is likely due to not being able to control for all factors, including early childhood and perinatal health. After controlling for as many demographic and institution factors as we could, including age, we found that the 6-year completion rates of student Aboriginal and Torres Strait Islander Australians were still, on average, 15 percentage points lower than that of other Australian students, which is consistent with other studies. Although the results from students belonging to 2 equity groups is not statistically significant, you can see that belonging to 1 or 3 equity groups and receiving some amount of income support can correlate with having an increase on completion rates of up to 19 percentage points. Age is a known factor that lowers the likelihood of completion, as older working age students may sacrifice more study time to obtain greater income. Student Aboriginal and Torres Strait Islander Australians are known to commence university studies later in life than other Australian students, with 24.4% of Aboriginal and Torres Strait Islander Australians being over the age of 24 at commencement, compared to only 9.4% of other Australian students. Across all starting ages, however, the student Aboriginal and Torres Strait Islander Australian completion rates remain significantly lower. The study found that student Aboriginal and Torres Strait Islander peoples are more likely to complete at age 18 than age 24, 1.8 times more likely to complete when receiving income support, and 0.14 times less likely to complete in 6 years if part-time. As I previously mentioned, this analysis was part of a larger project that was examining the significant social and health risk factors that prevent Australians from completing their tertiary studies, as well as the short-term income and employment outcomes of these tertiary graduates. My colleague Lewis Cowie has a presentation on the higher education completion rates for domestic undergraduate students who access mental health services online currently as an on-demand presentation. So please avail yourself of that video if you have time. So where to from now? We're currently finishing phase 2 of the project, which looks at the transitions from education to work. The project aims to gain a better understanding of student transitions from higher education to work. We're focusing on the post-study outcomes of bachelor students, and analyses will be stratified across equity groups and completion status. The outcomes from this analysis should be available online soon. So thank you for attending my presentation. The fact sheets for the completing the higher education project are currently available at the site on this slide. And if you have any questions, please write it in the question portal.
Thank you very much for that, Megan. A fantastic example of how data linkage can fill some of the gaps. We've been asking the question around completion rates in education for Aboriginal and Torres Strait Islander people for a long time, to have a look at that at the national picture. So up next, we have Dr. Allison Gibbard. It's my pleasure to introduce her. I've worked with Alison for quite a few years, and Alison is a research fellow at the University of Melbourne. For the past decade, she's analysed large linkage data sets to tackle Aboriginal and Torres Strait Islander health questions relating to perinatal health and cancer. She's also currently coordinating studies of Aboriginal and Torres Strait Islander children, child removal and developmental disability amongst Aboriginal and Torres Strait Islander children in Western Australia. So her talk is titled Health of Aboriginal Children in Western Australia, Do Grandparents Matter? I'll get you to share your screen now.
Okay, can you see? Okay, thanks, Galinda. I'm currently on the lands of the Awabakal people in Newcastle, and I pay my respects to their elders, past, present and future, and any Indigenous people joining us today. So this work's part of a much larger Aboriginal-led project called Defying the Odds. And as you can see from the logo in the bottom left, this project focuses on the early years of life. So Aboriginal and Torres Strait Islander communities are very diverse, and child rearing practices may differ, but there are some common threads. Children are highly valued. Raising children is considered a shared responsibility. And in addition to the hands-on care that grandparents provide, they may have special roles, including imparting cultural knowledge and strengthening the child's ties with the rest of the extended family. However, due to the ongoing effects of colonisation, many Aboriginal families are split through child removal, incarceration and early mortality. And these events may result in the child losing their grandparent early, or the grandparent becoming the child's primary carer. So, to the best of our knowledge, no quantitative studies of the relationship between grandparents and the health of Aboriginal children has been undertaken. There has been work in other settings around the world, and these have explored associations between having grandparents and child outcomes. So, for example, in the figure on the right, we can see the percentage of studies which found that having a living maternal grandmother had a positive association, that's not coming up, with child survival. So, yeah, in green, we can see the studies that had the positive association. So for the other 3 grandparents, there were fewer positive associations. It's worth noting that these studies were predominantly in populations with high child mortality rates, so pre-industrial times or in developing nations. Child development and wellbeing has also been studied, and there have been only a few studies of physical health. So we're interested in the question of whether a child's physical health is affected by having grandparents in their life. This is a difficult question to answer, particularly with administrative data. So our first step was simply to examine whether there is an association at all between the health of the grandparents and the grandchildren in their first 5 years of life. So our population of interest was children born 2000 to 2013 in the state of Western Australia. And the rationale for grandparental health was that very ill grandparents may not be able to care for their grandchildren, and in fact may actually need the family to care for them. So we used birth records, which included the children's perinatal outcomes, birth and death registrations, hospital separations, and emergency presentations. Western Australia's Data Linkage branch can link grandparents and grandchildren using birth records and birth registrations of the grandchild and their parents to make that link to the grandparents. So we began with over 34,000 children. Of them, though, 4,700 could not be linked to their maternal grandmother, and that was because the mother had been born outside of Western Australia. So we ended up with 29,410 children, and they had between them over 10,000 maternal grandmothers. Though all the children were Aboriginal, 60% of their mothers' mothers were Aboriginal. 7% of the maternal grandmothers died prior to the child being born. For health, for those that were living, we used the Charleston Comorbidity Index, a measure of health that's been validated for a variety of populations and outcomes. So the scores were based on diagnoses recorded in inpatient hospital records, and we used a look-back period of 12 months prior to the grandchild's birth. So 89% had a score of 0 or 1, and we categorised them as healthy, and 3% had a score of 2 or more, and were categorised as unhealthy. So many of the grandmothers were young, with a median age of 47 years. So just looking at one of the outcomes, this is the total number of days the grandchild spent admitted to a hospital in the first 12 months of life, including the time they spent in the hospital at birth. So in the kind of orangey reddy colour, we can see that children with healthy maternal grandmothers were more likely to have fewer than 5 days in hospital compared to the children with unhealthy or deceased grandmothers. So we also found that having a healthy maternal grandmother was associated with survival in the first 5 years of life, fewer emergency department presentations, and among the children who had a hospitalisation after their initial hospitalisation for birth, fewer cases of discharge against medical advice, and fewer cases where the hospitalisation recorded a diagnosis of malnutrition or anemia, but there was no association with stillbirth. So we also looked at the number of living grandmothers, and in the reddy orange, we can see that if there were 2 living grandmothers, the children on average spent less time in hospital. By contrast, the children with no living grandmothers in blue spent the most number of days in hospital. So we also looked at all 4 grandparents, and I'll just point out that the linkage rates, the other 3 grandparents was a lot lower, and those children that didn't link were more likely to be from socioeconomically deprived areas and remote areas. So we can see that the associations are weaker for the grandfathers on the right than the grandmothers on the left. So overall, we found that child health service use and survival was associated with the health of their grandparents. There were more associations and larger differences observed for the health of maternal grandmothers and the other 3 grandparents. And this study also demonstrates the value of linked data for research involving multiple generations. But there are some important limitations. We cannot determine the reasons for the associations from the work we've done. It's unknown if the grandparents were involved in sharing for the child or not, and other mechanisms may be behind these associations. For example, the grandparents and grandchildren may share a healthier or less healthier environment. Also, the Charleston Comorbidity Index may not be an appropriate measure of health for Aboriginal and Torres Strait Islander communities, and it may also not be appropriate as a measure of capacity to care for grandchildren. So, to address these limitations, the next steps we're considering are modelling to account for the shared environment or stratifying by remoteness and socioeconomic disadvantage, to examine whether the grandparents and grandchildren were in physical proximity or not. Was the grandparent recorded in hospital or emergency records in the same region as the grandchild? To stratify by whether the children were in out-of-home care, including whether they're in kinship care or with another placement. To look at family size, how many grandchildren did these grandparents have? Look in more detail at the different causes of hospitalisation and emergency presentation, and consider alternate measures of health for the grandparents. Also stratify by the Aboriginal status of the grandparent and measure grandparent health over time. So finally, I'd like to acknowledge the many, many people contributing to the Defying the Odds project. Thanks for your attention.
Great, thanks for that, Alison. We're going to move straight on to the next speaker now, Dr. Michael Green. And Dr. Green is the Brian Hennon Chair and Head of the Department of Family Medicine at Queen's University, and a Professor in Family Medicine and Public Health Sciences. He is a Senior Adjunct Scientist at the Institute for Clinical Evaluative Sciences, ICAS. And Dr. Green's research covers a broad range of health services and policy research areas with an emphasis on primary care, quality of care, equity in health and Indigenous health. And today he's speaking about linking population level data to examine First Nations people with diabetes, monitoring treatment and control of blood sugar and lipids.
Great, thanks a lot. Welcome everybody. I would like to start also by acknowledging the traditional owners of the land wherever you are, elders past, present, and future. And in my own city of Kingston, specifically, I am very privileged to live, work, and play on the traditional lands of the Anishinaabe and Haudenosaunee here in our beautiful city. This is a part of one presentation, part of a bigger project. And after me, you'll get to hear from Baiju Shah, who's one of our co-investigators. I don't have time to read everybody's names in our 10 minutes, but I wanted to acknowledge the scope of the team that supported this work. I also want to start by talking about engagement, because I don't think we can talk ever about using administrative or other data for research without talking about Indigenous data governance, which we've heard lots about today already. And Jennifer Walker, who was on the panel right before this, was one of our collaborators. So we had many partners. The Chiefs of Ontario is an umbrella organization for many First Nations in Ontario, and they were our primary First Nations partner in this, but we also did some qualitative work alongside with 5 individual communities. We had a patient advisory group, and we had a number of other policy partners. And if you're interested in our process, we actually have published the engagement piece of our project in CMAJ, a paper that Jennifer Walker published earlier. I also specifically want to speak to the importance of our patient advisors. In Canada, the strategy for patient-oriented research has really pushed for higher patient involvement in many forms of research, not only in Indigenous health, but across the board. And as this was a project supported by that strategy, we had an amazing group of patient advisors from across our province, from remote and urban, rural communities of different ages. And I really want to acknowledge the incredible insights they brought to the analysis of the data that we're going to present. So I'm going to talk a little bit about just one piece of our project, which was focused broadly on diabetes. and talk specifically on monitoring and control. And there's been lots of data presented on outcomes. Poor outcomes, is there more of X, Y, or Z of an outcome, but not as much really on what might be the pathways to leading to those outcomes. So we know that long-term blood glucose control as measured by hemoglobin A1C is closely linked to outcomes, that also control of blood pressure and lipids as other risk factors are also important. And that you can't empower patients to achieve long-term control without monitoring. Diabetes is not a disease that doctors treat. It's a disease that patients have to take care of themselves in multiple ways. And it's also something that's heavily influenced by community context, colonization and stress, so many other things. It's not simply a medical condition and are you giving the right sort of antibiotic or something like that, for example. Since we submitted this abstract, we have since published the paper in CMAJ, and the reference is there on the slide if you want to go in and read the full details. So generally, this is a data linkage study. We actually looked at data from 1995 to 2015 using annual cohorts of all patients with diabetes. We have a database here in Ontario where once you receive a diagnosis of diabetes, you're entered into kind of a chronic disease cohort. If you're in that cohort, you use the healthcare system within 7 years and you were alive and under 105 at the beginning of the year you were in. We, through our partnership with Chiefs of Ontario, had access to a data set on which individuals are recognized with First Nations status from the Indian Register, which is a federally maintained register in Canada, recognizing people who have a constitutionally recognized membership in a First Nation. We looked at rurality, and we also did some work identifying if people lived in a First Nations community or outside, and comorbidities as well. We then looked at monitoring for both hemoglobin A1C and lipids using tests completed, and we had some newer data on actual values from the Ontario Lab Information System. We did age and sex standardize this, and we also looked at mean values as well as categories for good, fair, poor control for diabetes, and for just good and bad control for lipids. And we also then looked at the types of medications used across to help achieve control. So I'm not going to ask people to read the numbers on this, but we have a table one that's very important simply because First Nations people in general and First Nations patients with diabetes are in particularly younger and more likely to reside in rural areas than other people in Ontario. So all of our analyses had to adjust for those or be stratified for them because they're important covariates that do have some influence on the results. So what did we find? These are, again, we said age was important. So we actually did our analysis. These are age and sex stratified graphs for different age groups rather than just say doing an adjustment for age. And the three colored lines, basically the yellow line at the top is the other people in Ontario. And then the blue line are First Nations people who reside in communities that are not identified as specifically First Nations. And the red lines are for First Nations people who reside inside First Nations communities. And what you see is a general pattern, particularly in the older age groups where you see more monitoring in the general population and the least for First Nations people inside communities. The size of the gaps varies a bit depending on the age group and the gender. But the overall pattern holds across most groups, exception this group down here of younger women. When similar pattern is seen also for monitoring for lipids. So we see that monitoring is really actually, even for the general population, not great where it really should be, but there's definitely a gap that persists. What about control? So what we see for control is that the mean hemoglobin A1C, which is highly correlated with outcomes, is over 0.5 higher for status First Nations in Ontario who had a valid result than it is for other Ontarians. And when we look at that by category, you see a big shift. So lots of people in both groups achieve good control. So I don't want this to be a deficits-based focus. You can see almost half of First Nations people with a diagnosis of diabetes have good control. But the proportion that have poor control is almost double what it is in other Ontarians. And when you take a deeper dive looking at where do people live in or outside of a First Nations community, you see the gap is bigger for people who live in a community that's identified as being specifically a First Nations community. When you look at rurality, it also really varies by rurality. So this may also be influencing that observation around First Nations communities, which may be more rural, in that both in First Nations people and other people in Ontario, if you are more rural or more remote, you are less likely to achieve good control of your diabetes. And I'm sure that there's lots of great reasons around food policy and access to many different sorts of services, as well as opportunities for types of recreation and things that are going to vary significantly in these areas. Lipid control, interesting, is a lot easier to achieve than sugar control. And what you see here is it's actually better in First Nations people than it is in the rest of the population. And when we looked at treatment, you actually saw that treatment was significantly higher in First Nations patients with diabetes with the correct statins as well. So pharmacotherapy, could you explain this by saying, well, maybe First Nations people are not receiving the same sort of treatment that they ought to compared to the rest of the population? In fact, what you see is a pattern where First Nations people are more likely to be on higher amounts of larger combinations of medications and less likely to be not on any medications than others in Ontario. So the top color of this graph is the people who are already on insulin, either alone or with oral agents, and the dark blue at the bottom is the patients who are not on any medications at all. So our few limitations: the algorithm's not specifically validated for First Nations. It can't distinguish between type 2 and type 1. There is some incomplete data. The prescription data is for provincial program only, and there are federal programs that also cover that, but the rates of data seem to be similar in the two groups. And interestingly, I don't know if others have found this, we couldn't adjust for socioeconomic status. The quintiles did not work well. Our traditional quintiles for measuring this were not micro level enough to help. So I'm going to wrap it up because that's my 10 minutes. But I think the bottom line for this is a pathway to improve care, because if we can improve glycemic control, and it's complicated, and we need to address colonization, those other barriers, then I think we can help to work at reducing rates of complications. Thank you.
Great, thank you, Michael. And we will move on straight to Baiju Shah, who's a senior scientist at ICES. Am I is it ISIS?
Not anymore.
Can we say that?
It's ICS.
ICS, okay. So he's an associate professor in the Department of Medicine at the University of Toronto and head of the Division of Endocrinology at Sunnybrook Health Sciences Centre. He's a clinician scientist who conducts health services and clinical research to understand care and outcomes for diabetes using population-level healthcare administrative data. So Baiju's particular areas of interest are diabetes in vulnerable populations, including visible minorities, immigrants, Indigenous peoples, and the uninsured, and long-term outcomes following gestational diabetes. Today, he's going to speak about peripheral arterial disease among First Nations people with diabetes in Ontario, Canada, linkage of population-level healthcare data. Take it away, Baiju.
Great, thank you very much, and good morning or good evening, wherever you are. I'm speaking to you from Toronto on what are the traditional lands of many First Nations communities, including the Anishinaabe, the Haudenosaunee, the Mississaugas, and the Wendat. And I recognize their enduring presence here and recognize also our collective responsibilities towards challenging colonialism and addressing reconciliation. So I'm also very fortunate to be presenting to you immediately after Michael's presentation just before, which really set a lot of the background for what I'm going to be talking about. So I don't have to get into a lot of detail about this work, but this was a large project with many investigators seeking to understand the impact of diabetes in the First Nations population of Ontario, when we were working with the Chiefs of Ontario and several individual First Nations as well to really understand this in more detail. So I get to focus a little more on the clinical things, which is a little easier for me. But as you saw in the last presentation, diabetes is really a major concern for First Nations people in Canada, and really significantly higher rates of diabetes in the First Nations people in the blue line here compared to amongst other people in Ontario in red. Diabetes, as you probably know, is a disease of abnormal blood sugars, but really the reason we worry about it is because it can lead to damage to blood vessels, which then leads to clinical complications. And this is a pictogram that shows sort of the many of the main complications that can ensue from diabetes. The ones that sort of get the most profile are heart disease and stroke, but today I'm going to speak to you about peripheral vascular disease. So peripheral vascular disease is similar to cardiovascular disease and stroke in the sense that it is caused by a narrowing in the large blood vessels, and in this case, the blood vessels that supply blood to the legs. And the symptoms that people with peripheral arterial disease have is intermittent claudication, which is basically pain and cramping in the legs when you walk. And it's sort of analogous to angina of the legs. And as you would have seen in the previous slide, one of the other complications that can affect the feet is this distal polyneuropathy, which leads to numbness, tingling, loss of sensation in the feet. And the two together of peripheral arterial disease and polyneuropathy can lead to significant problems for people with diabetes. So, for example, patients will develop foot ulcers because of loss of sensation in the feet and the potential to injure themselves without realizing it and then continuing to traumatize their feet. Then the lack of circulation means that these ulcers do not heal properly. You try to treat them with antibiotics, but the drugs can't get to the area of infection because there is inadequate circulation. And eventually this can lead to gangrene. And then ultimately the only treatment really once you reach that kind of stage is to remove the ischemic tissue with amputation. And so really peripheral arterial disease is a tremendously impactful and life-altering complication for people with diabetes. And in addition to being causing a lot of mortality, it causes a tremendous amount of morbidity. And so that's one of the things we wanted to focus on today. And we wanted to compare the treatment and complications of peripheral arterial disease between First Nations people and other people in Ontario. So as Michael mentioned, we used the provincial population-based healthcare administrative databases, and we were able to identify First Nations people specifically using the Indian Register. And through this way, we were able to therefore compare First Nations people with other people in Ontario. And we focused really on three main outcomes in this study. We looked at diagnostic testing for peripheral arterial disease. We looked at revascularization procedures, so surgical procedures that are attempting to try and correct the impaired circulation into the lower legs. And then ultimately, we looked at the rates of lower extremity amputations, which is, as I indicated earlier, the sort of end stage complication and the end stage treatment that's required when all other treatment modalities fail. And then we finally, at the end, also examined mortality for patients following amputation. So I will go over the results now. So first of all, we will look at angiography, which is, again, the diagnostic procedure to try and identify peripheral vascular disease. And as you can see here, other people in Ontario are shown in yellow, First Nations people are shown in blue. There's slightly higher rates of angiography amongst First Nations people compared to the general population, but really not significantly so. And certainly looking at the wide confidence intervals, it's not a large increase. Generally a decline over time as new modalities for diagnosis came into play, which we weren't able to capture, but this sort of is a consistent pattern that you can see. When we move then to revascularization procedures, we can see really very similar rates between First Nations people and other people in Ontario. Again, maybe slightly more revascularization amongst First Nations people, but really not to any large extent. And these rates have been fairly consistent across time. However, when we turn to look finally at amputation, we see really an enormously increased rate of amputation for First Nations people compared to the general population. And even by 2014, when the gap was starting to narrow, we still see a sort of 3 to 4-fold increased risk of amputation amongst First Nations people. When we look at mortality, I think, oh, sorry, before we get to that, we did also stratify by some of the factors that Mike showed you in the previous presentation. And across all factors, First Nations people were at increased risk of amputation. So both by sex and by age, really significant increased risks of amputation. So I think one important message, I think, from this is that the risks of mortality after amputation are really quite enormous for all people. The yellow line again is for other people, and the blue line is for First Nations people. And as you can see, the median survival after amputation in the general population is only about 4 years. And for First Nations people, it's only 3.5 years. And so the adjusted hazard ratio was 1.15, or in other words, a 15% increased risk of death after amputation for First Nations people. And as Mike alluded to in his previous presentation, we looked at actually a number of different diabetes complications as part of this work. And really, for most of them, First Nations people faced an increased risk of these complications compared to other people in Ontario. But that risk for amputation that I've just shown you is by far in a way larger than the risks associated with any of the other micro or macrovascular complications of diabetes that we studied in this work. So then, just to conclude and summarize the findings, we did find that First Nations people with diabetes did have comparable rates of revascularization procedures and diagnostic procedures to treat peripheral arterial disease, but amputations in fact occurred 4 to 5 times more frequently. And this suggests that perhaps First Nations people are being diagnosed, are getting delayed diagnosis of peripheral arterial disease, or are not coming to clinical attention until they're reaching those end stages of disease where amputation is the only option. And those earlier preventative treatments are not also at an increased rate because people are not being seen soon enough. So the median survival, as I said, is only 3.5 years, which is actually quite shockingly short, and on par with many terminal forms of cancer. So finally, I just want to end by acknowledging all of the co-authors for this study who you saw in the previous slide, our patient advisory committee, and our partners and funders. Thank you very much.
Great. Thank you, Baiju. So wonderful research from all of our speakers. And we had Megan's research that showed us how the Australian government data linkage assets can play a role in filling some of the gaps in better understanding the determinants of health. And this example, it was education and completion rates of higher education. And then we saw the identification how the effect of family on health and well-being can be identified as well. And Alison was able to show us that grandparents matter. Family and extended family for Aboriginal and Torres Strait Islander people is a very important factor, and perhaps data linkage can play a role in that. And we all know about diabetes and the impact that it has on Indigenous communities globally. And Michael and his team were able to look at monitoring and the control of diabetes. And Baiju here showed us the higher rates of amputations, and that perhaps delayed or undiagnosis of PAD really requires our attention into the future. So with that in mind, everyone online, we've got a couple of questions that are up, but if you have if you want to address the speakers now, please feel free. Firstly, and I know that Alison has already answered a couple here, but would you like to expand a little bit more on these questions? We've got a question from Hong Tran. So thank to Alison, thanks for great research. Thanks for great research. My question is, if you considered multi-level cluster in the analysis.
Yeah, okay, thanks, Kalinda. Yeah, so I have thought about clustering at the level of the grandparent.
Sorry, Alison.
Yeah, so as a next step in terms of the modelling, clustering at the level of the grandparent?
Yeah, so just on clustering as well, and I'm not sure if you have the information for this, but when it comes to kinship systems within Aboriginal communities, often a grandparent may not necessarily be a blood grandparent either. Do we have any information in terms of being able to link that information around kinship systems and extended family grandparents? So yeah, I have several mothers in my kinship system, and each of their grandparents have responsibility of me as well. So I'm just kind of wondering about that sort of understanding or that level as well, talking about clustering to grandparent level.
Yeah, so the way the system works is that, yeah, it is very much based on birth mothers and birth fathers. So we only really know the direct line of descent. I mean, we do get information. We can track who an aunt might be, or a grandmother's sister, for example. But yeah, I mean, in terms of knowing who's important in that child's life, we may not have that information.
And just very quickly on that before we move on to another speaker, is there potential to create that information in terms of survey development to be able to link that? I mean, if ultimately the aim of this is to provide information on supportive mechanisms for improving health and outcomes for Aboriginal and Torres Strait Islander people, then it's then about capturing those cultural understandings as well. So yeah, I just wanted to just make that as a comment maybe. But if you think that it would be useful to develop up something along those lines.
Yeah, so you're saying to develop large surveys to identify which relatives we should be concentrating on the most, yeah.
Yeah, to capture that sort of kinship understanding.
Yeah.
Because Western construct of biological descent doesn't necessarily relate to engagement with family members. So, but yeah, I just sort of put that one out there. I had a quick question for Megan. So, Madip, is it still, I mean, this is an Australian government data asset or
Yes.
program, sorry, that's resulted in data assets. With regards to Aboriginal and Torres Strait Islander or Indigenous data governance processes within that space, how have you guys tried to, I guess, wrangle within the sector? And I don't mean to put you on the spot here either. So if you, feel free to share as much as you can.
Can you, when you say wrangle, what aspect are you?
So what sort of engagement processes have you guys implemented within, one within the project itself, but two within the current system? So you may have multi-tiered governance processes, and so you may have project-specific advisory committees as an example. You might also have for the data assets themselves overarching advice or advisors as well.
Sure. I'm not involved in the assets themselves, so I can't really comment there. But for the project, we do have project-specific. We have an Indigenous advisory committee for the Department of Education, Skills and Employment that we have engaged on that particular project.
Great, thanks for that. We also have another question here for Alison. were the observed associations between grandparents and child health independent of the mother's health status?
Yeah, so we didn't look at that, but it's a really good suggestion and something that, yeah, we will look at in the coming work. Though it's going to be interesting because the vast majority of mothers are quite young. So in this sample, over half of them are 24 years or younger, and they're healthy. They're healthy, young, having children. So yeah, it's going to be interesting to see the numbers on how many where we can actually see a serious health problem or not.
Great, thanks for that. Oh, okay, and we have a question for Baiju as well. So thanks, Baiju, for a great presentation. Is it possible to elaborate further on your findings on the mortality rates after amputation based on their gender?
So that's a very interesting question. Thank you for sharing that. We didn't actually examine post-amputation mortality stratified by sex or by age. The reality is the number of amputations amongst women is relatively small. Most of them are amongst men for various reasons, and that's both amongst First Nations people and in the rest of the population. Part of that is behavioral, and part of that is risk factors. But we did not actually examine mortality by gender or by age, and I think that's actually a really interesting question, and that's something we should go back and think about.
Yeah, great, Baiju. I just have a quick query about the, I guess, the work, like both with Baiju and Michael. This is part of a large program of work. And within that, there's obviously lots of partners. Is this, I guess, an innovation in terms of data linkage programs with Aboriginal and Torres Strait Islander communities, and it's both for Baiju and Michael, but in Canada, or has there been a few programs like this historically, and in terms of, I guess, finessing and developing ways in which this work can go forward? And yeah.
You want me to take that, Baiju? I think it was a little different, and it partly relates to how ICES is set up here in Ontario, where it includes researchers from multiple institutions all across the province. So, Ontario has a population of about 14 million people. It's the biggest province in Canada. It has quite a few different universities, but it only has one ICES as the data source. And so the work and partnerships that have happened linking ICES to partners like Chiefs of Ontario at a provincial level with that group, and at a community level that we heard about earlier from Jen Walker about the applied health research questions and those things, has been around for a while. And we were able to leverage that for this project by bringing content experts together. So there was a core team of people who had developed a relationship with Chiefs of Ontario and worked on all aspects of the project and worked very closely all the way through with all the patient advisors. And then we brought in content and methods experts from other parts of ICES to help with the individual components. And so, at the end of the day, because we had, a big comprehensive report on diabetes generally, but then, there's about a dozen kind of context-specific papers that came out on those different sorts of outcomes that were of interest. And we're moving forward now in our next set of partnerships. It's moved into some new questions. I like about intergenerational diabetes. So I think this whole question about health across generations that we heard about was something that resonated with our partners as something to look at next.
And I know that you do some work in primary healthcare, and I was just wondering whether the engagement with primary healthcare is there as well. I mean, obviously this work and Baiju's work as well you know, primary healthcare plays a very important role in early diagnosis and, you know, ongoing care. So can you let us know a little bit more about, I guess, the primary healthcare space for that?
So we were able to actually, it's good that Baiju's on because he also worked on this other paper on utilization. So we did take a look at primary healthcare access and utilization and access to a family doctor and continuity of care and all those things that are important. And as you might expect, we found that there's areas where things need to improve. It's a challenge because there are First Nation specific healthcare systems that don't contribute data to the rest of the provincial data. And so that is something going forward on a kind of data linkage front where we need to fill in some of the gaps that we have to understand that better.
Yeah, that's really good news. And I think it's something that can be used by those primary healthcare services as well to advocate for resources and services as necessary as well. So I think, yeah, this data linkage work will play a very important role, particularly in such a, I guess, an extensive disease. We don't have any more questions. I've got a comment here from Ben, but just highlighting, just said, that's a very interesting point you make, Linda, and it goes back to Odette's presentation, thinking about how Aboriginal people are defined and measured. It sounds like family relationships are measured from a Western perspective. Does anyone know of any initiatives in Australia or, oh, sorry, I just lost this on my computer. Deal with me while I squeak. In Australia or beyond that seek to record family structure or other westernized variables from the community's perspective. So this will be our last question, but I'll just put that out there to all of the speakers. And yeah, so are there any surveys that people know of or any data collections or research that's been done that incorporates Indigenous understandings or knowledges around family dynamics, I guess, and family structures. And this plays into, I guess, the demography, and it could also play into even denominator stuff. So yeah, I'll just put that out there to the speakers.
I don't know of any myself. With the MADAP data, it can be possible to try and work out greater family language than just the direct mother-father, but that depending on what data you have access to, you may be able to look at some of that. But I haven't seen any particular data records of anything like that. Coming from a teaching background and teaching in remote areas, this isn't data, but you were allowed to, when you're getting permission from parents, you were allowed to consider kinship parents, not just direct birth parents. That's the closest thing I've come to seeing like that.
That's good to know, Megan. Might hit you up to have a chat about that into the future. Anyone else?
So I wasn't going to say that I've seen this done, just generally, I guess, going back to that question about child protection data, that that if a child's removed from the parents and placed with a kinship carer, then that will be recorded. Though I guess that's a very select group of children as well, and it's not necessarily going to be representative of the full kinship structure. I'm guessing qualitative work is needed.
Yeah, that along with the, you know, what matters work as well, in terms of what does well-being mean, and some of the work that Ray Lovett and Gail Garvey and others have been doing in this space, Sherry Carney. Yeah, it's a similar sort of concept in terms of being able to capture understandings and values. Yeah. All right, well, if the speakers don't have anything else to add, and you've got about 5 minutes, if there was anything that you wanted to just touch on quickly before we finish up, please do so now, or else I'm happy to end the session. No? All right, well, can we please all thank Ms. Megan Ladbrook, Dr. Allison Gibbard, Dr. Michael Green, and Dr. Baiju Shah. Thank you all for a fantastic session on Indigenous health and wellbeing, and good luck with the research into the future, and take care.
Thanks, Kalinda.
Thank you.